Well, good morning, everyone, and welcome to the WPS presentation on chronic care management. This will be providing an overview of this particular service. Couple of housekeeping things before we dive into the material itself. Number one, my name is Ellen Vera, and I'm one of our provider outreach and education analysts, and I'll be your speaker for today. The webinar is scheduled for 1.5 hours. In order to mark you as attended, you will need to be on for the entire length of the call. If it ends early, you need to be on until the end or until 12:30. That's 12:30 Central Time. We will receive a report from our vendor later today or early in the morning telling us who was on and for how long. As soon as we receive that, we'll be able to update the information in the Learning Center, and then you'll receive an email asking you to go and complete the additional modules. One module is who attended, and this is anyone that's sharing the monitor with you for today's call, for today's webinar. If you're the one who signed in, then your name will be what appears on the report. When you get that email, complete the Who Attended module with information on other registered attendees. We'll then be able to get them marked as having attended this also. We provided you with information in a resource section, which is a CMS Medicare Learning Network Matters booklet on chronic care management services. We'll reference this during the presentation, but you don't need to print it. If you choose, you can have it open while we're going through the information. I'm going to change screens here real quick. Okay, so this is, again, what we'll be talking about today, chronic care management. The next slide that we have really is just a disclaimer, and what this means is that the education is as accurate as we can make it as of today. Medicare rules do change often, as I'm sure you're aware if you've been with Medicare for any length of time. The Medicare rules and regulations are really the deciding factor as to whether or not Medicare will make payment for a particular service. We'll provide responses to questions based on the information that you provide to us, but again, the Medicare rules and regulations determine final coverage. And then Medicare prohibits recording of this presentation for profit-making purposes. We're going to take questions through the chat function. That'll be open for you. We have someone who is monitoring that. The person, one of my colleagues, Mary Muko, who is monitoring that, will make a determination when that question comes in as to whether or not she will interrupt the presentation with that question or whether she'll hold that question until the end. If she holds it until the end, then we'll be able to answer the question at that time. We will also have available for you follow-up questions. This will be a module. Once we mark you as complete, this is one of the ones that will open up. And if there are additional questions that you have following the presentation, you can include them there. One of the things that we're going to do for chronic care management is we're going to be doing education on this topic throughout the next year. And so as part of that, we are going to create what I'm calling as a living Q&A document. So each of the different educational opportunities that we have, we will be updating that Q&A document, and it will be available for you in our Learning Center where you'll be able to access that. Before we jump into the information, I want to turn the presentation over to Dr. Robert Kettler. He is one of our contractor medical directors, and we'll kind of discuss chronic care management and what we're doing with this. Dr. Kettler?
Thank you, Ellen. And hello, everybody. I have to say that I am very proud to be here speaking with you about this project, and I'll explain why in a few minutes. First, I'd like to give a little bit of background about this project. As Ellen said, I'm going to talk a little bit about chronic care management, why we think it's important, and then I'm going to turn things back to Ellen for the rest of the speakers and the rest of the content today. By way of background, in late 2019, CMS, or the Center for Medicare and Medicaid Services, issued what was called the MAC Innovation Challenge. And in brief, the MAC Innovation Challenge was a challenge to all the Medicare administrative contractors to identify services in their jurisdictions that were underutilized and come up with a proposal to increase utilization of those services. After a fair amount of consideration and data analysis, WPS identified depression screening as the service that we were going to work on increasing the utilization of. And I think that over the course of the next 2 years, we were really quite successful in increasing the utilization of depression screening. We did have to make some changes in how we approached it. We originally were going to have a fair amount of in-person education about the importance of depression screening, but as I said, this proposal was submitted in late 2019, and before we received word that it was accepted, the COVID pandemic hit the country, and for quite a number of months, no travel was possible. And then even as things began to open up, it was still difficult to do much in the way of travel. So most of the education that we provided was through other means. And Ellen and the rest of the PO department did a very good job. Matt Davis and his data analysis team also did a good job with some of the comparative billing reports that they sent. But using these various techniques, we were able to meet our benchmarks of increasing the utilization of depression screening in our jurisdictions. Well, in the latter part of last year, 2021, CMS issued another challenge, and this was to increase the utilization of various services in populations that were otherwise underserved. And again, the challenge to the MACs was to identify underserved populations, identify underutilized services, and come up with a proposal to increase utilization of those services. We again opted to try and increase the utilization of depression screening, but we also added increasing the utilization of chronic care management, which is the topic of today's talk. We were very pleased to see that both of our proposals were accepted, and you're going to be hearing more details about this. But as I said before, one of the reasons why I'm proud to be here talking about this is that a number of MACs did not have their proposals accepted, and we were the only MAC to get 2 proposals accepted. So I think that that does speak to the work that the people you're going to be hearing from today did on depression screening. In terms of chronic care management itself, I think that the way to look at chronic care management is it's a way to make sure that things don't slip through the cracks in patient management. I'm an anesthesiologist, but I do remember back when I was in training and was involved with the different types of ward medical care that things were very complicated, and it was hard to keep track of everything that needed to be done for patients. And so many times things just didn't get done as they should have. I think that the big advantage of chronic care management is it's a systematic approach to taking care of patients who have multiple problems, and it's a way to make sure that things do get taken care of and followed up on. And you're going to be hearing more details about this as we go on. There is a fair amount of evidence that chronic care management is a benefit to patients. In work that's been done in the Medicare population, it does indicate that chronic care management leads to increased patient satisfaction and overall increased patient adherence to the treatment plan that is provided for patients. With respect to a number of chronic diseases, congestive heart failure, chronic care management does seem to lead to improved patient knowledge of their condition, better medication adherence, reduced emergency department visits, and fewer days in the hospital overall. In asthma, chronic care management leads to better documentation of the treatment plan, improved patient monitoring by the clinical practice, and improved quality of life for the patient. And better documentation of the treatment plan may not seem like that much of an advantage, but when you consider how much care is provided through Medicare, where the documentation to support the care that is being provided is lacking, I think you'd begin to understand that improving the documentation of the care provided is something that's very important for all of us. For diabetes, chronic care management does seem to lead to a reduction in comorbidities, particularly cardiovascular disease, and it does lead to improved glucose control as indicated by the A1C measurements that are taken on patients. Now, this has been a very brief set of remarks. It's been very high level, but I think the more important information is yet to come. I will be on the rest of this presentation, so if you do have questions for me, I'll be available to answer them. But for now, I'm going to turn it back to Ellen. Ellen?
Thank you, Dr. Cutler. That was some great information. And as Dr. Cutler said, that's kind of the goal of the education that we're going to be doing, is to increase the use of the services and to increase the value to both the provider community and to the beneficiary community for this. The next person that's going to talk to us is going to be Matthew Davis. He is from our data analysis team. And so I'm going to share a slide of his. So Matt, I'll turn it over to you.
Thank you very much, Ellen. Hello, everyone. My name is Matt Davis, and I'm the manager of the Insight Data and Analytics team here at WPS Health Solutions. I wanted to just take a couple of minutes of your time today and give you a little bit of additional background into the data analysis that led us to pursue this effort, that is to increase the utilization of chronic care management services in both of our jurisdictions. Now, research shows that beneficiaries who live with multiple chronic conditions actually incur over 90% of all Medicare expenditures, and they also frequently experience care fragmentation for those multiple chronic conditions. In 2021, in both jurisdictions 5 and 8, there were over 2.4 million Medicare fee-for-service beneficiaries who live with 2 or most likely more chronic conditions, and that's almost 2/3 of the beneficiary population that we serve. Now, I'd want to contrast that 2/3 value of beneficiaries who live with 2 or more chronic conditions with the fact that only 1% of all of our beneficiaries in both jurisdictions received any chronic care management services at all. So, given that disparity in the prevalence of beneficiaries who live with multiple chronic conditions, and contrasting it with the underutilization of these chronic care management services, and now you start to see the primary driver for why we came about developing this program here. In addition to that, in our jurisdictions in the last year, over 1/3 of our beneficiaries who live with multiple chronic conditions had been to the emergency room for treatment. So the goals of our program will be to, first and foremost, increase the utilization of chronic care management services, and we'll include a lens of health equity into that, with a particular focus on the beneficiaries in our jurisdictions who may be historically marginalized or underrepresented. Then we'll also strive to observe a downstream reduction in emergency department visits for those beneficiaries who live with multiple chronic conditions as well. Next slide, please. So, to focus our educational efforts specifically on combating health inequities in our jurisdiction, we'll incorporate the Area Deprivation Index, or ADI, which is what you're looking at here. Now, the ADI is a measure of the level of disadvantage per census tract, a small geographic area, and it's based on the levels of income, education, employment, and housing quality. Now, looking at the map here, red is the most disadvantaged neighborhoods and blue is the least disadvantaged. So using the ADI, we've already identified a couple of geographic hotspots to target for our educational interventions in our jurisdictions. This could be places like Detroit, Michigan in Jurisdiction 8 and St. Louis, Missouri in Jurisdiction 5, but you can see many other opportunities that exist for us here in red as well. Now, if you practice in any of these red areas, you may already be aware of this, but if not, your geographic area is considered disadvantaged when compared to the rest of the nation. Again, while we will strive to increase the utilization of chronic care management services everywhere and to everyone in our jurisdictions, we will be paying particular attention to increasing its use in our most disadvantaged neighborhoods and communities. If anyone has any questions for me, I'd be happy to answer them right now. Otherwise, I will turn it back over to Ellen.
Okay, thank you, Matt. Mary, do we have questions for Matt? There are no questions for Matt. Okay. Let me switch screens again. All right, so these are the objectives that we have for today. We want to provide you with information on the value of billing the chronic care management services, which are really divided into 3 different sections: chronic care management, principal care management, and complex chronic care management. As Matt showed in the slide that he had with the percentages in each of the states of patients with 2 or more chronic conditions, there's a lot of patients out there. So the goal of this is going to be getting more patients to be receiving chronic care management, which is an advantage to the provider community because that's an increase in your revenues. In addition to that, as Dr. Kettler stated, it is a great advantage to your Medicare patients because just that interaction and knowing that someone is watching this stuff through using the chronic care management can help your patients comply better with the medical decisions that you're making, with the treatment plans that you have implemented for them, with their medication adherence, etc. So we want to provide information on these services so that you know that you can bill for these, how to bill for these, what are the procedure codes for these, etc. And then as Matt mentioned, the goal of this care really is to reduce the patient's need for other services. If chronic care management is happening for the patient, if the patient is in compliance with the treatment plans that your physicians and practitioners have implemented, then there's probably going to be less need for emergency room care, inpatient care, and more urgently needed office visits for you. So a good implementation plan will help free up some of your other time to see additional patients. And just an FYI for you also, as Dr. Kettler mentioned when he was talking about our depression screening initiative a couple of years ago, we are looking to partner with you and your organizations. If that is something that you're interested in, we would love to be able to come and talk to you about chronic care management. On our website, which is WPSGHA.com. You can go into the Topic Center, which is up at the top of your screen, and go into training. And we have information there on how we can partner with you. So here's what we're going to be talking about today. Excuse me a second. We're going to talk about patient eligibility, what the patient has to have, what the provider has to have, how to identify patient consent and when that is required, how to identify the contents of the chronic care management service, and how to document that. We'll discuss incident to billing. This is not a service that only the practitioner can do. Your clinical staff can be heavily involved in this, and we'll talk about how that works. Then we'll talk about billing, that's the particular procedure codes, and then we'll be able to open it up for questions. As Matt talked about, we have big computers, so we need to use them. And we do that through the data analysis. The information that Matt showed based on the slide information, the area deprivation index, it was really kind of an eye-opener the first time I saw that. Another piece of data that we requested, though, were the billing of these particular procedure codes. We wanted to know how many times these were being denied, how many times, and what were the causes of the denials, etc. So we took a look at some data, and for hospital outpatient departments, and you can bill for this service, there's a less than 1% denial rate. That's absolutely fantastic. For rural health clinics and federally qualified health clinics, and your offices can also bill Medicare directly for this. You will receive a separate payment for this. That denial rate is also less than 1%. For Part B services, denial rates are a little bit higher, but for the principal care management, we had probably about a 4% denial or rejection rate for J5. J8 had about a 7% denial or rejection rate. The other thing that we found interesting was that for jurisdiction 8, which is Michigan and Indiana, the billing was, of the total number that were billed under both of our jurisdictions, jurisdiction 8 had about 78%. Versus only 22% billed in J5. So that tells us, number one, that J5 has some room to grow there, and then really both contracts do. The denials were pretty straightforward. They were either part of the National Correct Coding Initiative, and that will be one of the future topics that we talk about. They were denied based on medically unlikely edits, and that has to do with billing the complex chronic care management and billing chronic care management by the same doctor in the same month, and that will be a future education that we do. And then also just duplicates. Duplicates tend to be one of our higher denials anyway. So let's talk about the patient eligibility, and this is both for chronic care management and then complex chronic care management. You can see there on the screen, the patient has to have 2 or more chronic conditions. Now, the MLN document that we provided to you as a resource has a listing of possible chronic care or chronic conditions. That's not an exclusive list. There are all kinds of things that could be considered chronic conditions for the patient. And you'll see the definition here. It's expected to last at least 12 months or until the death of the patient. And the disease process or the chronic condition places that patient at higher risk of death, acute exacerbation, or decompensation, or functional decline. Now, so let's talk about what exactly that means. If you have a patient that has high blood pressure, for an example, that can be a chronic condition. It's expected to last at least 12 months or until the death of the patient. High blood pressure is going to place that patient at higher risk. One of the things that is not in the instructions is that the patient has to be in a crisis situation in order for this to qualify. Another example that's actually not on the list, but is a chronic condition, is hemochromatosis. This particular disease causes the patient to retain iron. So even if the patient does not have iron overload, or the disease process has not affected organs such as the liver, such as the joints, etc., it still can lead to that. So when we're talking about placing the patient at higher risk, a patient who is at goal for their high blood pressure or at goal for their diabetes or their hemochromatosis, that still can count as part of this, because if they go out of goal, then it places them at higher risk. It is the condition that we're talking about, the chronic condition we're talking about, as opposed to the patient's status with that chronic condition at any given particular date. For the principal care management, what we look at here is it's going to be a serious or a single rather high-risk condition. Now you'll notice on here it's expected to last 3 months to a year or until the death of the patient. And then it has to place the patient at high risk. So that means your documentation will need to show why it is high risk for the patient. Now, generally speaking, when we're talking about principal care management, this can be a situation where the patient has experienced some type of exacerbation of this condition. The condition could have caused the patient to have been hospitalized. And so when that patient is now coming out of the hospital, then we're concentrating on this principal care management. A generalized statement is that primary care providers would do the chronic care management, complex chronic care management, and then specialty practitioners would do the principal care management. That's a generalization. It is not a requirement by Medicare. So you could be a cardiologist, for an example, and if you were the one who was providing most of the patient's care, you could be doing chronic care management or complex chronic care management, or you could be doing principal care management. It just depends on your documentation and what exactly it is you're doing for that patient. Now, if you downloaded the handout more than a couple of days ago, you'll notice that your handout actually says 6 months to a year. There's a discrepancy within what is published in that CMS handout versus what is published within the final rule. So it is 3 months to 1 year as opposed to 6 months to 1 year. This was actually published in the 2020 Medicare Fee Schedule final rule. So let's talk then about provider eligibility. You can see the listing there. It's the MDs or DOs. It's some of your non-physician practitioners. Also notice, however, that clinical staff is listed here. One moment, please. These particular services are very heavily involved with your clinical staff. There are procedure codes that identify what your billing practitioners are actually doing and the amount of time that they're spending. But a lot of the services that are going to be provided for chronic care management are going to be done by your clinical staff. And this will be under supervision by your billing practitioner. And that supervision is under general supervision, not direct supervision, which we'll talk about here in just a second. The next thing that we have then is patient consent. A patient has to agree to receive the service. Chronic care management services are non-face-to-face. And so the patient will be receiving a bill from you for their cost sharing without actually or without always having an interaction with you. So that's something that you would explain to the patient in getting their consent for this service. The fact that there is cost sharing. Generally speaking, it's about anywhere from $10 to $12, $13 is what the patient would be responsible for. Excuse me. You have to document that patient consent in the medical record. Now, this can be written or it can be verbal. It can be something gathered by the practitioner himself or herself, or it can be gathered by the clinical staff. You also need to provide the patient with how to contact your office in order to receive the CCM services. So it's an explanation of this is what we're going to be doing over here, which is, watching your test results, possibly having a conversation with you on compliance with treatment plan, that type of thing. And then if you have an urgent issue, here's how you get a hold of us. You do have to be able to provide care for the patient 24/7. Now, that doesn't necessarily mean face-to-face care. Again, CCM is generally non-face-to-face, but there has to be a way for your patient to contact you and say, hey, I'm kind of worried about whatever this is, what should I do with this? So that's part of the information that you share with them. So as part of that, for those patients that you're going to provide CCM, you want to make sure you have dedicated information for them. A lot of times when you call a provider office now, if you're calling to make an appointment, to ask about refills on medications, etc., the very first thing that you hear once the phone is answered is, if this is an emergency, dial 9 or hang up and dial 911. Well, for your chronic care patients, what you want to look at is how do they get to that clinical staff that can listen to whatever issue it is they're having and then advise them on what they need to do, whether it is to go to the emergency room or to call an ambulance, or maybe they just need to wait and take their blood pressure again in 30 minutes, whatever your treatment plan calls for. The next thing is that only one practitioner can furnish and bill CCM in a calendar month. Now, I want to expand on this statement just a little bit because a patient can be receiving chronic care management services and principal care management services within the same month, just not by the same provider. And then, of course, the patient can revoke chronic care management if they choose to, and that revocation then is at the end of that calendar month. And you want to let the patient know that also. So let's talk about electronic record requirements. And this is an area that providers have talked to CMS about a lot. It's information that CMS has published. And one of the things is we know that not everyone is using certified electronic health record technology right now. However, for chronic care management services, you do have to use certified EHR technology in order to capture certain information. And that's the information that's listed there on your slide. The patient demographics, the problem lists, their medications, and any medication allergies. Other information that you have, which will be part of your medical record, does not have to necessarily be in a certified EHR technology program. Now, you can see here that for the patient demographics, etc., you do have to use a certified EHR technology as of December 31st of the previous calendar year. And there are several different versions out there that are considered certified technology right now. Whatever is listed, that's the one that you need to be using, or one of those. So let's talk about how we start then chronic care management services. Number one, there is a required face-to-face service for new patients and patients not seen within the previous year. Excuse me. So that means that your billing practitioner, either it's a new patient to them or someone within the same group with the same specialty, or that patient has not been seen within the previous year. You can see a listing there of what is considered that initiating visit: the annual wellness visit, welcome to Medicare visit, or initial preventive physical exam, a comprehensive evaluation and management visit. That's a little bit misleading because it does not have to be the highest level of an E&M service. It just has to be an E&M service. Another service that can stand as the initiating visit is the transitional care management. For transitional care management, you have to have a face-to-face visit either within 7 or 14 days of the discharge. That will also count as an initiating visit. If you have an initiating visit with that patient, then your documentation will have to show that you discussed chronic care management with the patient during that visit. So that can be the assessment of the patient, it can be the care plan of the patient, or the beginnings of the care plan of the patient. But the medical record has to show that discussion. Unfortunately, if the medical record doesn't show that, then that would not count as the initiating visit. The other thing is that if it is not a new patient, or the patient has been seen within the previous 1 year, then you don't have to have a separate initiating visit. You can begin the process of chronic care management through a contact with that patient. And that contact can be either with the billing practitioner, or it could also be with the clinical staff to kind of begin the process of assessing the patient, developing the care plan, and then putting that chronic care management in place. There is also an add-on procedure code. Wait a minute, my screen has just moved around. Sorry about that. Okay, we have an add-on procedure code, the G0506, and this is in addition to that initiating visit. So Medicare will pay for this once when chronic care management starts for that provider and that patient, which means, of course, that if the patient switches to another provider, that other provider would have an initiating visit, and they could also do this add-on code. So what this means is that if you're having to spend an additional amount of time in doing the patient assessment, it's going to be a comprehensive assessment, in developing that care plan, then you can build this add-on code in addition to the code for that initiating visit. Again, the E&M service, annual wellness visit, etc. You would need to document not only the time spent with your patient, but then also the extensive assessment that you're doing and the extensive care plan that you're starting to develop for that particular patient. So let's talk about the comprehensive health plan itself. In the CMS document, this is on page 8, and you can take a look and see the information's there. The care plan that you develop is going to cover not only those things that you're treating, but everything that the patient has. So unless you're doing principal care management, if you're doing chronic care management, it's going to include everything. So even if your patient has end-stage renal disease, as an example, and you're not treating that, the nephrologist is treating that, that's still going to be part of your care plan because you're going to be developing and working with that nephrologist as part of the chronic care management. It doesn't mean that you're going to take over care of that chronic kidney disease or the ESRD, but you're going to be watching what's happening with that other practitioner and with the patient. So for chronic care management, you want to kind of think of yourself as the coach. You're not necessarily the one throwing the ball or making the touchdown, but you're coordinating everything that's happening. So you're aware of everything that is happening. You know not only what the nephrologist is doing and what their treatment plan is for the patient, but you're also aware of what the cardiologist is doing and what their treatment plan is for that patient. One of the things that comes into play here is really medication management. I'm sure you have seen patients where they have multiple practitioners and they're getting medications from all of these different practitioners. But when someone really sits down to look at all of the medications, what it's supposed to do, what the interactions are, what they find is there's a whole lot of those medications that are working against each other. You know, so the patient is taking this one, but this other medication is discounting everything that this medication is supposed to do for them. So the medication management is real important for the patients. And again, having those conversations with the other practitioners. So the first 2 bullet points there, where the patient is at right now. So are they at goal with their high blood pressure? Are they at goal with their blood sugars? Where do you want them to be? What is your goal for that patient? And part of that is going to be responsibilities for the patient also. You know, the patient has high blood sugars. Part of what you want them to do is you want them to exercise 3 times a week. Well, that's part of your treatment plan. That's part of what you develop with that patient. It's part of your ongoing care for this chronic condition. Are they compliant? Are there things you can do to help them be compliant, etc.? Identifying other resources. This is where you're talking to the patient about that nephrologist or about the podiatrist or the cardiologist, etc. And then you'll identify in your care plan how often does this need to be reviewed. So if, for an example, you could have a patient who has high blood pressure and diabetes. Okay, high blood pressure is controlled by medication. Blood sugars are being controlled right now through exercise and diet. So what's your determination as the practitioner or the clinical staff, how often does this need to be reviewed? Do you need to provide a service monthly for the patient to check in and verify they're taking their blood sugars, they're checking their blood pressures, what those are? Do you have information within your plan that will tell the patient, you know, if your blood sugar goes to this, then you need to contact us. Or if your blood pressure goes to this, then you need to contact us. And then also you want to share that care plan. 1 second, please. So you want to share that care plan not only with the patient and or their caregiver, but you also want to be sharing that care plan with other practitioners who are involved in that patient's care. And then you want to know their care plans. Again, remember, the person billing for chronic care management is really the coach. They're, you know, making sure that everything that needs to be done is being done for that patient. Dr. Kettler talked earlier about, you know, with large practices, with all of the things that your practitioners are responsible for doing for the patients they care for, there are times when things can get missed. Well, that's part of management, so that what and stuff, and the patients are being cared for. All right, so the next thing that we want to do as part of chronic care management is you want to manage care transitions. And so what we mean by that is when the patient has gone to the emergency room, they have been discharged from the hospital, discharged from the skilled nursing facility, as the one who's billing for chronic care management, then you need to know about this. So that's part of the information that you'll provide to your patient. You know, if you go to the emergency room, you need to contact us, you know, once you're stabilized so that we can gather information from that entity. You want to make sure that if your patient starts going to another doctor, that you're aware of that, so then you can include that in your care plan. You can include information from that other physician. You also want to be including any referrals that you're making. So for an example, if you're treating the patient's high blood pressure and you're treating their diabetes and you're thinking there's now something going on with their heart, okay, you can refer that patient to a cardiologist. You'll just notate your referral. You'll interact with that cardiologist to make sure that you're incorporating their plan as part of your care plan also. One of the questions that we received from the pre-submitted questions, it says, can we do chronic care management if the patient was an inpatient during the month? And the answer to that is yes. You just need to meet the guidelines. Chronic care management, hang on, it didn't move. Chronic care management is a monthly non-face-to-face service. So with each of the different procedure codes, which we'll show in just a second, there is required time that you need to be spending on the patients themselves. And then with complex chronic care management, there is also a medical decision-making function that comes into that, and that has to be documented. You want to document what you have provided for the patient. So for an example, if you have checked in with the patient and you have had a discussion with that patient concerning their blood pressures or their blood sugars, and you have, as part of that discussion, have determined that no, they're not, you know, exercising the way they're supposed to, They have not been following the diet plan, et cetera, et cetera. Then you want to document that and document the time that you've spent on that. Now, we did a survey, and in fact, the survey is still open. If you want to take it, we published it within our e-news, both on Monday and on Wednesday, and it's been published for a couple of weeks now. It will come out again on Monday and then also next Wednesday. And we ask about barriers to providing this service. Well, one of the barriers that people had mentioned was trying to keep track of this time. It can be within your medical record. It could be a database that you set up. It's really your determination as to how you want to keep track of the time that you spend for Susie, that you spend for Bill, that you spend for Joyce. Medicare doesn't have any specific requirements on that other than just, you have to support the procedure code that you have submitted. You want to update information as necessary. So again, in our example where the patient is now going to a cardiologist, you're going to indicate that. And you'll indicate any interaction you had with that cardiologist and then update your plan accordingly. And then, of course, coordinate with outside resources, practitioners, and providers. Now, when we're talking about that last bullet, coordinating with these other entities, this can be not only emergency departments, hospitals, skilled nursing facilities, other doctors or practitioners, but it could be community resources also. That's part of what you want to provide to the patient is community resources that can help them comply with the treatment plan that you want for them. You want them to exercise 3 times a week. Well, maybe you tell them about the Silver Sneaker organization or classes that they have where they can go and they can have a good time exercising with people that, kind of have the same problems as they do. You could tell them about the new belly dancing class at the local YMCA. Maybe that will convince them that, yes, they really can find exercise fun, and yes, they really need to comply with that. We have received several versions of a question concerning face-to-face services. As we talked about, chronic care management is generally a non-face-to-face service. So you don't have to have, obviously, a face-to-face. You don't have to have an interaction with the patient in order to bill for the service. Now, if you do, that's part of what you document, but it's not a requirement. So we're a little confused with kind of where this question is coming from. If you're providing a face-to-face service, then you want to really look to see whether or not that's a separately payable service. So for an example, for the month of August or September, you're doing chronic care management and you have the patient come in and you have a face-to-face E&M service. That face-to-face E&M, as long as it's medically necessary, all the rules are complied with, then you would bill for that separately. And then if you met all the qualifications for the chronic care, then you could bill for that separately. So we're a little confused and don't really understand where the face-to-face question is coming from. Another question that we had was whether or not the clinical staff could provide a face-to-face service in the home. And again, we're not really sure what type of face-to-face service would be provided. That would be part of the chronic care management service. So if this is a question that you have and have submitted it to us already, or a question you have, if you would include that and kind of an explanation as to what it is Go ahead.
Ellen, I do have a question for you.
Sure.
The question comes from Margaret. She works in pain management, seeing chronic care patients. Pain impacts functionality, quality of life, etc. Margaret's question is, have you seen pain practices using a CCM program? They have to determine if injections are helpful or not, and gather information for prior authorizations via phone.
The chronic condition of chronic pain can qualify a patient for chronic care management services. It's any chronic condition that the patient has that meets what we talked about earlier, 12 months to a year, places the patient at high risk. And so chronic pain can definitely be one of those diagnoses. And then in order to bill for that, you would just need to comply with the requirements of the service, just like anyone else would for any additional chronic conditions that you have. Just an FYI for you too, CMS did have information within the proposed rule, the 2023 proposed rule on creating a chronic pain management service, and that would be similar to, although there are some differences, but similar to chronic care management, but we'll have to wait until the final rule to see what they actually decide.
One more question, Ellen.
Sure.
I'll wait till you turn your mute on. This is for slide 14. The question comes from Deb, and she asks, so we document time spent on any of these items for reimbursement, or does only the time spent on patient count towards CPT?
Mute button. Sorry about that. I lost my mute button. Well, it's any of this. I think what you're asking is the time only directly with that patient? And the answer to that is no. It's doing any of these things that you're doing for the patient as part of chronic care management itself. So for an example, that second bullet point, the evaluation of patient and treatment goals. So you could be evaluating what's in the patient's medical record, as an example, and at the previous face-to-face encounter, your physician ordered particular lab tests. So you're reviewing those lab tests and determining whether or not the results of those lab tests mean that you need to change anything in that care plan. You know, maybe the INR test is showing that the patient's blood is too thin or too thick, whatever the situation is. So you're reviewing those. That's not a direct interaction with the patient, but it is providing chronic care management services. Okay, Mary, is there another question we need to take now? Or,
Not right now, Ellen. Thank you.
okay, thank you, Mary. All right, the next thing that we want to talk about then are incident 2 requirements. And as I stated earlier, when you're looking at chronic care management services, your physicians and your non-physician practitioners are the ones who are in charge. They're really the coach, okay? However, a lot of the services that are going to be provided can be done by your clinical staff. So that means then that the clinical staff have to meet the incident 2 guidelines, meaning that it has to be either, there has to be an employer-employee relationship with the billing practitioner. This is provided under general rather than direct supervision, meaning that the practitioner does not have to be in the same place as the clinical staff, excuse me. Sorry about that. And then the clinical staff have to have access to the patient's medical records. So, you know, as we stated earlier, part of chronic care management services is that you have staff available to that patient 24/7. So if the patient wakes up at 2 o'clock in the morning and they're short of breath and they don't know what to do, they have to be able to call your staff, and they wouldn't necessarily be calling the practitioner directly, but they have to have a way to contact your office to say, hey, this is what's going on, what do I do? And that clinical staff has to be able to get to those medical records to see what's happening with that patient. And then that last bullet point is really, really important. We have seen for providers who are doing chronic care management that they're kind of across the board. They have directly employed staff that are doing the chronic care management, which is perfectly acceptable. In that case, the patient gets to know your staff, Susie, so they can build up trust with that person. In addition to that, there are also offices that are contracting with care management organizations, and as long as it meets the Incident to guidelines, then that's acceptable to Medicare. But look at that last bullet point. That person who is talking to that patient or that person who is providing the chronic care management services has to be physically within the United States. If they are somewhere outside of the United States, Medicare does not pay for that service.
Ellen,
Yes.
I have one more question. The question comes from Angela, and she wants to know if there are advanced paramedics that can help provide medical or social services within the care plan to the patient in their home. Could that time be counted towards the clinical staff time for CCM?
Okay, Mary, ask me the question again, please.
Sure. This is Angela's question. If there are advanced paramedics that can help provide medical and social services within the care plan to the patient in their patient's home, could that time be counted towards the clinical staff time for CCM?
Okay, the answer to that is that that person has to be considered clinical staff. And the definition of clinical staff is within the CPT book itself. So you'll want to look at that particular definition. CMS has not defined, excuse me, CMS has not made a separate definition. Whenever this particular question comes up, they refer back to the CPT book. And so for this particular person, that person would have to meet the definition of clinical staff. They would have to meet the definition of incident to. And then again, we have that other part of the question, what is that person doing in the home? You know, what are the face-to-face services that are being provided? Again, we kind of keep getting this question. We're a little unsure of what's happening. So Angela, if you would include that face-to-face portion as part of a follow-up question, we would really appreciate that.
Ellen, I have two more questions. Do you want to wait till the end?
No, go ahead. We'll do those right now.
Okay, the first question comes from Tasha. Can more than one of the patient's providers bill CCM in a month if in a different practice or specialty?
No, the patient can only be receiving chronic care management services, which includes chronic care management, the lower level, or complex chronic care management from one practitioner within a month. The patient can receive principal care management and chronic care management or complex chronic care management within a month. So they can have one person doing principal care management and another one doing CCM, but they can't have multiples doing CCM.
Thanks, Ellen. One more question.
Mm-hmm.
Can the incident to requirement be met in a hospital, outpatient clinic, or office?
Yes, and that's a very good point, and we're going to talk about how hospital outpatient departments bill for that in just a second. And then that will also be more specific education that we do in the future for hospital outpatient departments, and we're going to do the same thing for rural health clinics and federally qualified health centers. As we talked about earlier, we're going to have this living Q&A document. As part of what we want you to include within your follow-up questions from this presentation today is what you want to see as education in the future. If there are questions you have, we're going to try and do another educational event. We have an educational event that's not advertised yet. I'm hoping it will be advertised next week, although don't hold me to that. But we are going to do a separate education just on the initiating visit and what all it goes into that. So we will be doing education, but yes, a hospital outpatient department can bill for that. Okay, Mary, anything else before we move on?
No, that's it.
Okay, thank you. Great questions, everyone. So the next slide that we have talks about the principal care management, and it has the procedure codes. So you can see here we've got two differences. The first one is the practitioner. So this is going to be the person who can bill Medicare, your MD or your DO, or your non-physician practitioner. It is only their time that is counted for the 99424 or 425 procedure code. And you can see that first 30 minutes and then each additional 30 minutes. The way that CMS has this worded is that you would need, in order to bill that 99425, you would need to have an additional 30 minutes before you would be able to submit that. So it would not be that halfway point. You couldn't bill it when you hit 15 minutes. The next procedure code, or the next set there, is the clinical staff. And so this is services by the clinical staff under the general supervision of that billing practitioner. And again, shows you the different time there. The other thing that I want you to know, though, here is that your practitioner time can go into your clinical staff time. So for an example, your practitioner during that month provides 10 minutes worth of care for that patient. You can count that 10 minutes worth of care in that clinical staff time. You can't go the other way. Clinical staff time does not count toward the practitioner time. In addition to that, you can only bill one set of the procedure codes. So for an example, your physician provides 30 minutes of time, your clinical staff provides an additional 30 minutes of time. You would not be able to bill that 99424 and then the 99427. You have to either put your time in the practitioner time, which is only practitioner, or you'll put your time in the clinical staff time, which can include either practitioner or clinical staff. So in the example that I just gave, you could bill either the 99424 by itself to reflect that practitioner's 30 minutes of time, or you could submit the 426 and the 427 to reflect both the clinical staff's 30 minutes and that practitioner's 30 minutes of time. So, kind of your choice. The next one that we have then is the chronic care management itself. The same thing holds true. You'll document the time that you have spent, can document the activities that you're doing, and then the rule concerning practitioner versus clinical is the same in this one too. Your practitioner's time can go into your clinical staff time, but your clinical staff time cannot go into your practitioner time. Now, here is complex chronic care management, and this one confuses people, okay? Because number one, look at the time here. We've got practitioner procedure codes, which if you'll notice are the same as the chronic care management procedure codes. And then we have different, however, clinical staff procedure codes. The difference here, though, is that for complex chronic care management, it is not only the time that is spent, but it is also the medical decision-making that goes along with it. So one of the questions that we received said something to the effect of, I have provided 65 minutes worth of time during this month. Does that mean I automatically get to count this as complex chronic care management? And the answer to that is no. Documentation will have to show that moderate or high-level medical decision-making provided for that patient in order to count this as complex chronic care management. And then, we talked about what some of the denials were, and one of those denials had to do with medically unlikely edits. What we have found, and in fact there was an OIG report on this, Office of the Inspector General report on this, in that providers were billing both chronic care management and complex chronic care management, and you can't do that. That's kind of double billing for the service. So you want to make sure you're keeping track of what's going on with that patient so that you can get the time in correctly and also can determine whether it's complex or whether it's simply chronic care management. So the next thing that we have are some billing instructions that are dues. You can submit the chronic care management during the same month as transitional care management. You just want to make sure that you separate the time and the services. You can't count any, one period of time toward both of those. You want to bill monthly for CCM, and that's chronic care management, complex chronic care management, or principal care management when you have met the requirements. And so really you want to be billing at the end of the month because it's that monthly service. If you bill at the end of the month, that will prevent you from getting that denial when it's really complex chronic care management, but you've already billed for the chronic care management. The next bullet point we've already talked about, practitioner time can count toward the clinical staff time. And then you want to take advantage of the National Correct Coding Initiative edits because there are some editing out there where these particular codes go into other services. So you want to take a look, see if anything is part of your service, and then also see where any modifiers are available. That will probably be a topic of future education also. Some billing instructions. Yes.
One more question. Megan wants to know, does the practitioner have to bill out for CCM, or can it be the clinical staff only?
Okay, well, the clinical staff cannot submit a claim to us because they're not an eligible practitioner. The claim has to come into us from the the billing provider, the MD, DO, or the non-physician practitioner. I think what the person is asking, though, is whether or not the practitioner must provide a service in order to bill for CCM, and the answer to that is no. The clinical staff person, for any given particular month could have been the person who was providing the CCM. But as long as it's documented, it meets the Incident 2 requirements under general supervision, that's acceptable to Medicare. Okay, so on this slide are just some billing instructions. Don't submit both a practitioner and a clinical code. Don't use the complex and non-complex. The next two are really things that are part of that National Correct Coding Initiative, part of the rules. You cannot bill chronic care management the same month you're doing home health or hospice supervision, or if you're billing for certain assessment ESRD services. You're not going to report prolonged care, in the same month. Now, as I'm sure you're aware, there are a lot of changes that are coming or have been proposed for 2023. We went through the changes for E&M services back in 2021, and there will be new prolonged care codes. If you're doing an inpatient service or an office visit, you're not going to bill prolonged care in the same month that you're doing chronic care management. And then, of course, that last bullet, your time only counts toward CCM. It can't count toward anything else. And then the next thing that we have, rural health clinics can bill for this. You see the procedure codes there, that G0511. And what we mean by submit the procedure code either alone or with other services, this qualifies as your visit. So if you're paid, a rural health clinic is paid under the all-inclusive rate, this is the all-inclusive rate procedure code. Federally qualified health centers are paid under the prospective payment system. This is that qualifying visit code. There's a lot of things that RHCs and FQHCs can't bill separately for. They're part of their cost report. The CCM, chronic care management, is one that you can bill separately for. For those of you that represent RHCs or FQHCs, be sure and include in your follow-up questions any specific questions you have. We will be doing separate education for RHCs and FQHCs. Hospital outpatient departments may also submit this, and so this would be the clinical staff time, obviously, and what all of the Incident 2 requirements would still need to be met for the hospital outpatient department. So there's a little, some differences with the HOPDs in that the staff are going to be employed by that facility, the hospital outpatient department, as opposed to necessarily directly employed by that practitioner. And then, of course, it is still general supervision. Documentation would support whoever is supervising that. And then both the hospital outpatient department and the physician can submit charges. This is one of those exceptions. Excuse me. Documentation, again, has to show who's doing what and who's spending what time. Hospital outpatient department billing will also be a separate one that, separate education that we're doing. Additional information, verify with the patient no one else is billing. Remember, only one person can bill for a particular patient. Let your patients know how to contact you. Provide the patient with a copy of the plan. As Dr. Kettler talked about earlier, hang on one second, please. As Dr. Kettler talked about earlier, the interactions that you're having with your patients, the fact that the patient knows there's somebody on the other end that's paying attention to them, can help your patient to be more compliant. And providing them with a copy of that care plan that says not only what you're going to do, but also what they're responsible for doing is a way to help that patient kind of move forward on that. And then that last bullet, excuse me, that last bullet says don't submit when a patient is attributed to your practice as part of a CMS demonstration. So this could be primary care first. There are several different demonstrations out there, and as part of those demonstration projects, patients are attributed to your practice. So it's kind of the patient is assigned to your practice, and whether or not you meet the goals of the particular demonstration has to do with those patients assigned to you. So if Susie is attributed to your practice as part of a demonstration, then you don't want to submit CCM for Susie. You can for Bill because he's not attributed to your practice.
And Ellen?
Yes.
I have another question in this question, Megan.
Mm-hmm.
This one pertains to something you want to put me on mute? This one pertains to something that you just talked about on the last slide, and that is the care plan. Megan wants to know, do we have to provide them with a copy of the care plan every so often, or just when it has changed?
You need to provide the patient with a copy of the care plan when you develop it. And anytime you are making any revisions, whether minor or major, to the care plan, then you need to provide a copy of that to the patient. Okay, and Mary, do we have any other questions?
Not at this time. Maybe you can remind everyone how they can ask a question?
Sure. To ask a question, you want to go into the chat function and make sure that you are indicating all panelists. That way, Mary, who's watching our chat and the questions coming in, will be able to see that. And then just enter your question there, and we'll be able to answer that, hopefully.
And there are no questions.
Okay. Just a couple of other things that we're going to talk about real quick. Let me get down to this. Please provide us some time to receive our report from the WebEx vendor. Generally, that's going to take at least a couple of hours. So if you get done with this call and you go in and you try and do into our Learning Center and try and complete modules, it's not going to open for you. But we should have that no later than the end of the day today. So we'll be able to take care of that, and then you'll receive an email showing that we marked you as attended, and then the rest of the modules will open up. Please complete the post-assessment. Again, we want to make sure that our education is providing you with what you need in order to bill for this service successfully. As Dr. Kettler talked about, it is not only a benefit for you, in additional reimbursement that you could possibly receive, it is a great benefit to your patient. It's where, by the actions and things that you take, the plan that you put together, It will be able to help that patient prevent emergency department visits and having to go into the hospital and urgent care office visits, etc. So we use that information from that post-assessment to see whether or not we've hit the mark. So we want you to complete that. We really want you to complete follow-up questions and think about, how the interactions between you and the patient are going. Are you doing this service for patients right now? If there's information that you need about how to get started, include that in that follow-up questions. We will be developing, again, that living question and answer document, which means we're going to be updating all the time. And then we will be developing future education based on the questions that we're receiving from both the pre-submitted questions, the follow-up questions, and then also the survey that is still available. Again, it will come out on Monday within the listserv. The link will be there. You can go in and you can take the survey. We will have that survey open up until September 22nd, where we can get information back from you. So Mary will ask. Go ahead.
Okay, just a couple of things, Ellen. You want to put me on mute? One of the questions was, when will the living document be available? And I responded and said that, we do allow 10 days for follow-up questions to come in. So typically it depends really how many questions come in with that 10 days. Do we need to send the questions out for expertise or people to comment on? But our goal really is to have that document within 30 days. But remember, this is what Ellen called a living document. So as new questions come around or new questions from additional events that we'll be holding come forth that we need to answer, we'll be adding those to that document. Typically, when we update an asset like that, we would send out a notification in news, letting people know that there's been updates. So watch that, and if you're not already subscribing to our news, please do so. One more thing, Ellen, before I let you go, because there's no additional new questions, but we're circling back to those slides, 17 and 18. They have both practitioner CPT codes for CCM and complex CCM, and the comment is that these are the same on both of the slides, and I believe you addressed that, but can you clarify about which codes are really the same and which are different?
Sure. When you look at the two sets of procedure codes, and in fact, let me see if I can go back to that particular slide. Okay, yeah, if you look at the chronic care management, the practitioner slides, the 99491 or 437 are the very same if you're doing complex chronic care management. That's just how CMS has got this set up for right now. The times are the same, etc. It's when you get into that additional time for the clinical staff. So you can see here the clinical staff, that 487 requires at least 60 minutes worth of time in addition to the practitioner's moderate or high level medical decision making. If you go to the other code, the chronic care management, in order to bill for clinical staff, you just have to have at least 20 minutes worth of time. So your practitioner is kind of equal on both of them. It really makes a difference for your clinical staff depending on which service that you're doing. And remember, it's not just time alone for that complex chronic care management service. Documentation also has to show that moderate or high level medical decision making for that particular patient. Okay, Mary, anything else?
There are no further questions.
Okay, well, my clock is showing 12:29, so I'm excited we ended our education on time today. I want to thank all of you very, very much for attending this presentation today. As Dr. Kettler talked about and Matt talked about, we're extremely excited about this particular challenge, about looking for ways to increase the use of these services. Again, not only is it additional reimbursement for our provider community, but it is great care for our patient community also. And really it just supplements the great care that practitioners are providing already. And by complying with the rules that go along with this service, it's something that you can receive payment for. Again, we should have everyone marked either very late this afternoon, tomorrow morning once we get that information back. And so thank you all very much and have an absolute wonderful day.